Welcome back to Healthcare Rounds. I'm John Marchica, CEO of Darwin Research Group. Today, I'm super excited. I've got Tyson Frodin, who is Assistant Vice President of Pharmacy with MultiCare, one of the top health systems in the Pacific Northwest. And Tyson is a leader, truly, and an innovative voice in pharmacy. So I'm really psyched today to talk about some of the cool things that they're doing at MultiCare. And so without further ado, Tyson, welcome.
Thanks, John. Pleasure to be here. Super excited for this opportunity to share.
And as I said, I'm excited too. So just a quick little backgrounder for our audience on what got you to where you are today at MultiCare, and then we'll dive into it.
Sure. Well, I'm a Idaho State pharmacy grad. So went to Idaho State there in Pocatello, Idaho. Upon leaving pharmacy school, I actually did the junior co-step with Indian Health Services, the Department of HHS, and the Public Health Service. So I was a commissioned officer for 3.5 years. And while I was on the Navajo reservation, I actually got a ton of experience doing telehealth, which kind of led further to my, development and career. After 3.5 years of being with the Public Health Service in the Indian Health Services branch, I took a role working for a critical access hospital down in southern Idaho, where I'm originally from. It was North Canyon Medical Center in Gooding, Idaho. And the beauty of being in critical access is you get a ton of breadth across all areas of the pharmacy enterprise. You get to be the director, you get to be the purchaser, you get to be the clinical coordinator. You get to wear multiple hats and be a jack of all trades and an expert of all trades when working in critical access. And one of the things with critical access is the fact that you don't have a ton of resources to help support pharmacy. Usually it's a one-man show with one technician, and you work Monday through Friday from 7 a.m. to 3:30 or 4 p.m. And so there's a lot of time that after-hour coverage is not available for critical access pharmacies. And so with that, and a big motivator for driving innovation and change is student debt, in my opinion, and having a ton of student debt I was trying to get taken care of. I created my own telepharmacy service where I was able to cover 7 hospitals throughout the state of Idaho after hours as if they had 24/7 coverage. And so with that, it was a great opportunity. Absolutely loved what I got to do with telepharmacy and expanding access to care within the state of Idaho, where I'm originally from. And it was awesome. Because of that experience, I decided to go back to school, and I got a master's in healthcare administration through the University of Minnesota. So go Gophers. And from there, I left North Canyon and took a chief operations officer role at Bedawant Community Hospital in St. Mary's, Idaho. So another critical access hospital. That's where I cut my teeth. I'm very passionate about rural healthcare and access. And then from there was an opportunity with MultiCare. MultiCare being very aggressive in their growth, looking to move into northern Idaho, western Montana, Alaska, and Oregon. There was an opportunity for me to come to MultiCare as an AVP of pharmacy to oversee their pharmacy supply chain, rev cycle, and technology. And, based off my prior experience, having done all of that in critical access, it was just a great fit. And so from there, back in 2020, I came to MultiCare, and I've been in my current role for about 5 years now.
So I can understand, wanting to go into or getting the advanced degree in public health, and just once you had that critical access experience. But I'm wondering, were there any lessons from kind of those early years? You mentioned telepharmacy, but were there any lessons that you were able to bring to MultiCare as as an AVP that you could see right away? Because it's a big system, but I know there's also a fair amount of rural care that MultiCare is associated with as well.
Yeah. So once again, when it comes to MultiCare, currently we've got 13 hospitals in our health system across the state of Washington, and they're all acute care hospitals that are fairly large. 100 beds plus for the most part for all of our hospitals. The larger facilities, 350 plus beds. And so when you look at a lot of our acute care leadership or directors of pharmacy, they're very acute care focused.
Sure.
One of the benefits of being in a critical access rural facility is just having breadth and access to roles that normal directors of pharmacy wouldn't have. I had created a formulary in our electronic health record. I worked closely with our billing team. In critical access pharmacy specifically, we have our hand in every clinical cookie jar throughout the hospital. And so being able to help support and work with lab, respiratory therapy, imaging, it gave me kind of a leg up and understood the operations of healthcare a little bit better than some of our other acute care pharmacy leaders based off of their sole focus on just operations within a pharmacy. And so for me, and knowing and understanding the benefit of having critical access hospitals within your health system where they're cost-based reimbursed, they have swing bed programs. And so you're really trying to target how do we decrease the cost of care in the acute inpatient setting that's DRG bundle based. You get a specific amount of reimbursement dollars for each ICD-10 code at discharge. How do we maximize that opportunity? How do you either look to partner with critical access hospitals throughout your system or incorporate critical access hospitals in your system so you have that swing bed status? That way you can really focus on decreasing length of stay, as well as looking at therapies that normally you wouldn't get reimbursed in an acute care facility. With cost-based reimbursement in critical access, is there the opportunity to ship those patients to critical access where they do participate in swing bed status? They do get those swing bed dollars, but then they're also cost-based reimbursed. So how do you look at strategic placement of patients across your different levels of care, whether it's swing bed, whether it's being in a critical access, or whether it's being a full admit in acute care? How do you get strategic in placing those patients to really drive the maximum reimbursement and value of your health system based off of the class of trade or the level of care that person needs to be treated appropriately?
Well, one of the things in doing my homework, I noticed in a recent discussion that you had highlighted a 24% reduction in pharmacy spend. Can you talk a little bit about what some of and you've already mentioned a few of those, but what some of those strategies were to have that kind of view on cost reduction, but also how that relates to supply chain and, what you were able to do there when you came into MultiCare?
Ooh, great question. So there's really 4 specific areas that we targeted as MultiCare to drive that reduction. So you hit the nail on the head. Since 2021, MultiCare, we've been able to reduce our inpatient drug spend by 24% over those 4 years, which is remarkable, especially when looking at industry benchmarks across other acute care, not-for-profit, non-government facilities. They're seeing about 7% reduction during that same time frame. So we really went above and beyond. And one of the first areas we looked at was just the org structure of our pharmacy supply chain team to really maximize, what that drug spend was. So the first thing we looked at was just looking at our current org chart and the role that each of our purchasers played. So we have 13 hospitals. Each site would have their own purchaser. And quite frankly, they were kind of off doing their own thing. There wasn't a whole lot of coordination. It wasn't centralized. There was no real specific strategy when it came to each individual site, highlighting and documenting what their preferred NDCs were for that site. So one of the things that we did is we created a centralized, coordinated pharmacy supply chain structure where we're able to identify 3 core centralized purchasers that initially started reviewing all of the other sites' orders before they were submitted. Now, it was a lift to be able to do that work, but where you have 3 experts when it comes to purchasing and knowing and understanding what those preferred NDCs are that drive the most value for our system, they are able to review those orders and update those preferreds across our system. So within about 6-month time frame of having them review those orders, we were able to generate about $650,000 in savings just on
Wow.
those initial orders and selecting the appropriate preferred product within our wholesalers in that wholesaler platform. So we're McKesson, we work in McKesson Connect and just selecting and identifying what those preferreds were. Now, once that initial lift was done, we really took that job off the frontline workers and placed that on our centralized coordinated purchasers. That way, behind the scenes, as new opportunities were identified, they could select those preferreds and drive that savings automatically. That way we weren't waiting for 13 different purchasers to be able to identify and make those changes. It's kind of like herding cats sometimes when there's that many irons in the fire.
Sure.
And by having it centralized and coordinated and having it done behind the scenes, we could initiate savings as soon as something was identified across our entire enterprise. So that was first and foremost, just looking at that org structure, creating that centralized approach. The second piece is we did a huge overhaul of all the pharmacy automation across our inpatient settings. So we are a BD facility. We use Pyxis med stations, BD carousels, anesthesia carts, so on and so forth. And so we did a whole overhaul across our entire system to make sure that everybody was on the same instance of Pyxis CS. We had to update our different regions so they were all in the same Pyxis CS system, running 1.6. And with that, we created a perpetual inventory across the system. So essentially, once again, with our centralized coordinated purchasing team, we had a line of sight to all of the products, the NDCs, the expiration dating, the values on hand, the par values, to really drive a perpetual inventory. By having that data, being able to have a perpetual inventory, we could take actionable steps based off of that data. Now with the BD platform, we were able to overlay data analytics. It's called Health Site Inventory Optimizer, or HSIO. And there's 3 key areas that we focused on specifically with HSIO. Optimizing par values based off of the data from all of the medications that were being dispensed across our system. Really trying to limit the amount that's in our machines to make sure that we didn't have excess that would expire, but then also prevent stockouts. Because nursing workflows, they're dependent on those automatic dispensing machines. We want to make sure that they have enough drug to be able to treat their patients, but at the same time, not have excess inventory that's just sitting out. The next area were meds not used within 90 days, as well as expired meds. So how do we really reduce our inventory values? How do we decrease that carrying cost and ultimately decrease that expired med value that's just doing a part of business? So really utilizing and focusing on that data analytics across all of pharmacy automation. That was number 2. Number 3, having been a purchaser at a site, doing all the purchasing, managing inventories, and coming into a health system of 13 hospitals and going from $1 million in drug spend a year to about $365 million from drug spend a year, it was very apparent that there needed to be some sort of data analytics to help us manage that spend. So I really worked with multiple partners that are currently in the marketplace that do that for health systems. Now there was probably 5 or 6 different companies that we looked at, and based off of their platforms and what they were able to offer, we selected a data analytics partner. And with that, just in the last 2.5 years, we've been able to reduce our drug spend by $7.5 million across 13 hospitals.
It's incredible.
About $365 million in spend. And so with that data analytics, really being able to review our wholesaler in every medication that they have in their catalog. Now, for MultiCare, being in Washington, there's 2 distribution centers that we purchase from through McKesson, one in Wilsonville, one in Puyallup. Or better said, one close to Seattle and one close to Portland. And based off your geographic location, that determines which DC sends drug to you. When you're utilizing the McKesson platform, you're able to see what they've got available in your specific DCs. And that's really it. There's really not an opportunity to look to see what there is across the country. Having access to this data analytics, however, we now have visibility to every distribution center that McKesson has across the country. We also have visibility to every price point for every specific NVC across the country. So based off of this data analytics, we ingest our pharmacy spend They're able to break down all of our spend based off of GPO, WAC, and 340B buckets. They take that total spend, divide it by the total denominator, so we get the blended cost of each NDC. This data analytics can then take that blended cost and compare it to all the other blended costs based off of MultiCare's utilization to really identify what the best product is for MultiCare based off of how we're dispensing it across our hospitals. And so based off of that, we were able to drive $7.5 million in savings over the last 2.5 years and maintain around a 12-to-1 ROI. Now, I'll take those figures any day. Those are, home run initiatives. And so based off of that, we've been able to drive significant change. So that was key point number 3, is just having that data analytics to really manage our drug spend. Now, the fourth part, by having that data analytics, it really kind of paints the picture of what the current model looks like when you're using your traditional GPOs and your traditional wholesaler arrangements. Now, we focus on GPOs to go out and do negotiation on our behalf to get the best price at a GPO price point, as well as work with manufacturers and wholesalers to offer the best value to us as a health system, via purchasing. Now, with the data analytics, however, we were able to identify strategic partnerships outside your traditional GPO and wholesaler relationships that drive significant savings for the health system. And having that data analytics at your fingertips, it allows you to either partner with other secondary wholesalers at looking at pricing based off of providing your utilization, different price points that would guarantee opportunities to switch. And for MultiCare, for us to make a change at the NDC level, we have to generate so much savings per NDC per change per year, or it's not worth the lift.
Sure.
And for us, based off of the data, we identified a price point of $5,000 per NDC per year. If we weren't able to save at least that amount, it wasn't worth it to MultiCare to make the change. You've got purchasers who are bringing product in, they're capturing barcodes, they're capturing NDCs, they're submitting tickets to Epic to get those NDCs stat, as well as working with your 340B team to update your 340B crosswalks to make sure you're accumulating on the correct NDCs to get those 340B accumulations and drive savings. So by having that data analytics to be able to see where those opportunities lie, to work with manufacturers so that they can bypass GPOs and bypass the traditional wholesalers. So they're not looking for GPO awarded agreements or wholesaler, generic opportunities, to be able to go direct, and then manufacturers being able to keep those admin fees in their pocket and pass on enhanced savings opportunities to health systems. That's where we've seen a ton of benefit and opportunities. So by using that data analytics to go out and identify new strategic partnerships outside your traditional GPO and wholesaler agreements and arrangements has driven significant value for MultiCare. And that's going to be one of the things that we look to capitalize on moving forward when looking at integrated services centers. So looking at having a centralized buying location for our entire system where we purchase centrally, and then create a hub and spoke model with the automation and technology we have to do a hub and spoke model where we purchase centrally and then ship out to each individual sites. Those are the opportunities that we're looking for moving forward to drive significant value and change.
Tyson, there's a lot there. I mean, we could probably take each one of those things and do a whole podcast on that. But just kind of reflecting back, what I'm hearing is, of course, standardization, minimization of variation, which back to my Dartmouth days, that's rings very true with me, right? So minimizing that variation, the application of smart technology throughout the process, and all of these things for me, how do I ask the question? There's sort of a traditional view of pharmacy as this cost center. It's just all about costs, and then there is a more enlightened view, which another conversation we've kind of hit on a little bit, which is more of a strategic look at pharmacy, where you're bringing more to the table than just cost reduction. And you've alluded to that here. You talked about strategic partnerships outside of the traditional GPO and wholesaler relationships. But how do you get organizationally in a health system your size? How do you get organizationally sort of the C-suite to view pharmacy as a real opportunity, as a real kind of strategic asset to the organization? What kinds of, what do you do communication wise, and how do you elevate it to that level? Because it seems like you're doing it, but for other, health system folks that might be listening to this pod, how do you get there?
Yeah. So great question, and great opportunity for pharmacy to really shine within a health system. So first and foremost, MultiCare has been amazing because pharmacy has a seat at the table when it comes to strategic plans and strategic partnerships with the health system. And for some of the opportunities that we've been able to execute on, specifically in that ambulatory space. Now, there's two sides to the coin that you have to look at. You have your inpatient, which is DRG,
right?
Bundled payment. So it is a cost containment strategy on the inpatient side. But then you've got your outpatient side or ambulatory side where you drive margin and revenue for your health system. And so being strategic and really understanding how you can diversify that ambulatory setting to drive value, margin, and revenue for your health system. So, inpatient side is going to continue to get hit by CMS and Medicaid reductions year over year. We're seeing about 2.3% increase year over year. Yet we're seeing 8% inflation across, whether it's pharmacy supply chain, whether it's your regular supply chain, med-surg supply, so on and so forth. So how do you really diversify that ambulatory space to offset and subsidize the inpatient space? So some of the opportunities that MultiCare has looked at is how do we really capitalize on our infusion, on retail pharmacy, on specialty pharmacy, and on home infusion. Those are 4 key strategies that having somebody from pharmacy at the table with your C-suite to highlight the opportunities and show the value as well as the success that those areas have had to drive revenue or margin for the entire system. So at MultiCare, we got 8 infusion centers that are 340B eligible, which we try to capitalize on to drive value and margin for the system. We've got a robust specialty pharmacy that we're continuing to grow by getting more access to limited distribution drugs. We've really grown our retail footprint. We've got 13 retail pharmacies across our system, and we're doing everything in our power to make sure that MultiCare prescriptions are staying within MultiCare pharmacies, specifically our retail, specialty, and infusion sites. So for us, we're really a health system where we're making sure that all of our needs of our patients are being met by our service lines, specifically when it comes to pharmacy in that ambulatory space. And so based off of that, as well as having these tools with data analytics to look at pricing, if you're able to go out and work with manufacturers looking specifically at sub-WAC, at sub-340B pricing, to be able to maximize what your Medicare reimbursement is, usually it's ASP plus 6%, it makes it easy to identify, okay, which therapies are best suited to meet the care of our patients and drive the most value for a health system. So a MultiCare, specifically when it comes to looking at infusion, whether it's hem-onc, whether it's specialty, whether it's rheumatology, GI, neurology, so on and so forth, there's different agents that are out there. And if there's a biosimilar available, we really look to strategize off those biosimilar opportunities. And how do we leverage competition between either the brand name or the biosimilar to be able to get the best pricing possible for our system? And having that data analytics really aids in doing that. And when you know what reimbursements are, it really makes it easy to identify what the delta is. So there's either a cost saving strategy when you could be stepping over, dollars of revenue to save pennies on the dollar, really targeting what those revenue generating opportunities would be to drive underlying revenue and margins for your system. So for all of the opportunities that we've deployed and being able to have a seat at the table to be able to express the opportunities and the value of what pharmacy has to offer, as far as not just being a cost center, which is typically what you see on the acute care side, but a system service line that drives significant revenue and ultimately margin for the bottom line, that's where we've had a ton of success, and that's where we've been able to shine across our health system.
So a couple of follow-ups on that. When you talk about the distribution or the centralized distribution that's coming, do you see that as this is a two-part question. Do you see it as an opportunity for more of that direct contract, direct distribution to your system? In other words, you want to be able to warehouse those things. And then related to that is the specialty pharmacy. And I guess maybe these aren't related questions. Maybe we can handle both of them. But the one thing that you had mentioned was, kind of keeping the patients within the pharmacy. How do you do that, especially in specialty pharmacy, when you have, the PBMs and other big box, folks that want to take those, as soon as they get on the specialty farm, they want to take them away. So how do you, there's a distribution question. And secondly, how do you keep people within the MultiCare network for pharmacy care?
Well, actually, I'll try to answer your second question first, and we'll go back to the distribution question with the Integrated Services Center. So we've been very strategic when it comes to specialty, looking at getting URAP accreditation as well as ACHC accreditation. With those accreditations, it gives us better access to limited distribution drugs that may make it harder for other health systems to have access to. So for us, it's all about how do we get access? How do we partner with either wholesalers or manufacturers to get direct access to those drugs? That way, answering your question, we're able to keep MultiCare patients within the four walls of MultiCare facilities, whether they're infusion, whether it's specialty, retail, so on and so forth. So really making sure that we're building out that specialty footprint to be as robust as we possibly can to get access to limited distribution drugs. Now, when it comes to the hub and spoke model, specifically looking at integrated services centers, centralized distribution centers, whatever acronym you want to call them, so essentially having your own internal warehouse, that is a huge opportunity for both the inpatient side, that's a cost containment strategy, as well as the ambulatory side that drives revenue. From an inpatient standpoint, by having space, which most pharmacies, we don't have a lot of space, and space is a hot commodity across health systems, you don't have the opportunity to look at bulk forward buys to drive enhanced savings because you just don't have the space to be able to store that medication. If you've got that space and you've got the data analytics and you know what your price points need to be to drive savings and where that needs to be, then it makes it very easy to work with the manufacturers to go direct and look to bypass the traditional GPO and wholesaler strategies that we currently see ourselves in. And so by having that space to go out and say, hey, we're willing to look at either 6 months to 1 year commitments with terms and conditions based off our actual utilization, we're looking to buy, can we do a 6-month forward buy? Can we do a 12-month forward buy? And have the space to warehouse that drug and have a perpetual inventory system to make sure that we're using it up before it expires. We're able to get it to the sites where they need it, when they need it, and drive significant savings. So you're looking at the bulk forward buys. There's the opportunity for shortage buys as well, as manufacturers are sitting on inventory and it's starting to age and it's coming closer to expiration. They're looking to liquidate that inventory. So if you've got the space and the data analytics to know how much you can use before it expires, that really drives a ton of opportunity for a health system to decrease their costs. Now, there's also other benefits. We've seen all-time high drug shortages across the pharmacy supply chain space. We've also seen significant challenges when it comes to IV solutions. So being able to have that space to have buffer stock to help mitigate drug shortages or IV shortages before they happen is a game changer for how we're able to treat our patients, ensure that they've got access to the medications that they need to be healthy and progress clinically as a patient. Now, we know that, there was the huge incident with Baxter and the North Carolina plant got shut down because of flooding. Mm-hmm. There was about a 4-month window there where it was very hard to come by IV solutions. With an integrated services center and having that 3-month buffer stock, a health system wouldn't have even felt the impact of that shortage because they would have had that capacity to store that drug or that IV solution and cross-dock it to their integrated services center. So those are the opportunities that I see on the inpatient side specifically. Now, on the outpatient side, if you've got that space, you can also look to minimize a lot of the WAC exposure if you're 340B entity. Now, if you have your data analytics, you know your price points, you know what your utilization more than likely will be.
Tyson, let me interrupt you a second. For the not so financially literate in health system pharmacy, can you go in a little bit more detail? I don't want to get too far in the weeds, but I just think it merits explanation that WAC differential in 340B and why that's so important.
Oh, absolutely. So when it comes to 340B entities, there's the opportunity to participate in the 340B program. Now, there's different ways you can qualify, whether you're a critical access hospital, whether you're a disproportionate share hospital where you treat so many indigent patients. It really is an opportunity to stretch limited federal funding to help cover and offset some of the costs associated with these indigent patients. So 340B program is huge for health systems. Now, when participating in the 340B program, you have to be able to administer drug to 340B qualified patients in an outpatient setting. So whether it's in your EDs, whether it's in your infusion centers, whether it's in your ORs, whatever the outpatient setting may be, you have to be able to administer to a qualifying 340B patient there. Now, to initially get a purchase that qualifies for 340B, you have to purchase at the wholesale acquisition cost or the WAC cost, wholesale acquisition cost. Now, WAC cost is generally much higher than your 340B costs and or your GPO cost, your group purchasing organizational costs that are negotiated for you by the GPO. So those are the three buckets that we're constantly monitoring. You've got your 340B spend, you've got your GPO spend, and then you've got your WAC spend. And to be able to get 340B accumulations, purchases that qualify for 340B, you have to have those initial purchases that are hitting your WAC accounts. And WAC accounts, once again, typically being your highest spend areas. So one strategy to go about to limit that WAC exposure is looking at these bulk forward buys where you're able to work with wholesalers to negotiate better sub-WAC pricing for those initial purchases to decrease the overall cost of that purchase. And so by having an integrated services center and having space to store that drug and knowing your utilization rates and data, you could work potentially with the manufacturer to say, hey, I'm looking to buy 6 months worth of this drug because I know that that's how much I'd probably have to purchase to get my 340B accumulations to start purchasing on 340B. Is there a way for us to negotiate on that WAC pricing at a sub-WAC price point to decrease that cost and limit that WAC exposure to the organization?
Makes sense. That makes a lot of sense. Well, we only have a few minutes left, but I want to get to a question that I've asked before in different ways, but I think you're in a unique position to be able to answer this, and that is, I've been witnessing the pharmaceutical manufacturers over the last decade or so, and a common refrain that I hear from them is trying to build more value in the relationship with large systems and with folks like yourselves. So if you were advising, if you were talking to, sort of and I understand, by the way, it's going to be different for different manufacturers and the kind of, the product mix that they're bringing and the importance of those products to your system and all of that. But if you were to give some advice to these manufacturers on creating more value in the relationship and creating more value in what they're providing for your patients, what are some of the things that they should be thinking about? The Pfizers, the Mercks of the world, what should they be thinking about when trying to bring more value to you? Does that make sense? Is the question? Okay.
It's a very timely question. And it's really because now that more health systems are deploying this data analytics opportunities across their health systems, now is the time for health systems and manufacturers to start working directly together. How do we start looking at how do we bypass the traditional GPO and wholesaler models? So prior to having data analytics, manufacturers would reach out to me specifically and say, hey, here's our new portfolio. Here's a list of all of our NDCs. If you can let us know which of these NDCs interest you, and you can pull your utilization so we know how much you're using. If you can pull some price points so we can see, what is your purchasing WAC, GPO, and 340B, maybe we can come up with the strategy or a price point that works for MultiCare to drive value of purchasing either A, direct from us as a manufacturer, where we ship it to you directly and bypass the GPO and the wholesalers, or is there an opportunity to look at local agreements where we're determining a price point and we're setting that price point through your wholesaler? That way you're able to purchase through your normal process, through your normal wholesaler process, where you're able to order the lowest unit of measure and have it delivered next day. Well, I never had the time, the resources, or the bandwidth to do that myself.
Sure.
And we rely on my technicians who are purchasing experts that don't have the Excel pivot table, capabilities or understanding. It was always a knee-jerk, automatic no. I just don't have interest or the time, the resources, or the bandwidth to do what you're asking. But now that we have this data analytics, in a matter of 3 clicks, I can produce a report that has the NDCs that I'm interested in, that they're manufacturing, that I can purchase, that I'm currently purchasing from somebody else. I've got my utilization. I know my price points that I would need to have to either have a guaranteed switch, which is $5,000 per NDC or more, or market competitive backup pricing, because we're seeing all-time drug shortages the last 4 years. And so by having backup pricing already in place, if my preferred product does go short, there's another product that has a great price point where I can move to continue to drive value for my organization. That's huge. And so as more health systems bring on this data analytics, to be willing to partner with them based off of the same data, to be able to look at either local agreements where we're able to get great pricing loaded on our accounts through the wholesaler, where we can follow the normal, SOP when it comes to the work that we're doing as far as purchasing, and or look to go direct. And if you've got that hub space where you can do those direct purchases, those bulk forward buys that are usually at a significant discount, that's what's going to drive a ton of value. So for help for these different manufacturers be willing and wanting to participate in these direct or local agreement opportunities with health systems. Now, I will say this, John, to each manufacturer that I've reached out to proactively, now that I've got this data at my fingertips, they've been all more than willing to partner with MultiCare. In fact, they're asking, when will you have your 100,000 square foot facility open so that we can start looking at these 6-month, 1-year terms with T's and C's based off of our utilization to really move the needle. And as we go down this route, you're seeing more health systems bringing this on. Currently we're purchasing it over 90% through our traditional GPO and wholesaler models. When we get to the point where we've got our integrated services center, we'll be looking to purchase 70 to 80% direct and only using 20 to 30% of our direct spend to purchase through the traditional methods for low volume, low utilization, high cost drugs, where it would just make sense to get it from the wholesaler versus going direct and having terms and conditions based off of utilization.
So everything that we've been talking about, Tyson, it feels like very much so a business conversation. You're talking about inventory management. You're talking about, of course, supply chain related to pricing and contracting strategy, holding costs. And we can go on and on. I'm not going to repeat everything that you just went through. I'm wondering, because a lot of the conversations that I witness on the manufacturer side have to do with total cost of care arguments, as well as, especially if it's a newer type of drug, patient journey conversations and everything around kind of getting to that patient experience, access issues and things like that. Are those things that are primary conversations for you, or is that more of kind of like a MultiCare pop health question, or like a medical director sort of question? How do the patient experience, the patient journey, the total cost kind of conversations, how do those hit your desk, if at all?
Well, they definitely do. And that's one of the key committees that I participate on is our population health committee, where we're specifically looking at how do we manage that. So we are a self-funded health system. We have our own employee health plan. We do partner with not-for-profit PBM, but we're really trying to manage the total cost of care when it comes to our employee health plan. But there's different areas in there. So I'm responsible for pharmacy procurement and across the entire pharmacy enterprise. So there's the acute care, which once again is kind of a cost containment, looking at, is there
Right.
generics available? How do we negotiate the best pricing? There's the ambulatory side, which is specific to looking at infusion, oncology, hemonc, rheumatology, GI, neurology, some of those bigger specialty areas. There's the employee health plan, where we're really trying to, once again, limit the total cost of care. And there's different variables that you have to look at, like you had just mentioned, access. Is it self-administrable? Can you do it at home? Can you get it through specialty? Do you have to go to an infusion center? What's the cost to have it administered? Those are all key elements when looking at, okay, what does this business pharmacy strategy model look like for each of these specific areas? And so by having pharmacy at the table, because we're the medication experts, now that we've got data analytics, now that we're doing more contracting, now that we're looking at the total cost of care to the health system, depending on the class of trade, the location, the setting, pharmacy offers a ton of value of being at the table with your CMOs, with your employee health benefits plan, with your HP partners or HR partners, looking at your employee health plan and the total cost of care. Pharmacy has a lot to offer. And as more health systems have their chief pharmacy officers or assistant vice presidents of pharmacy at the table who understand, the procurement piece, the strategy piece, the total cost of care piece, the patient satisfaction, the provider satisfaction, the pharmacy satisfaction piece. Those are all key elements that need to be identified and discussed as you're making these decisions to offer the best value to your patients, to your providers, to your nursing staff, and to pharmacists.
So, wow, there's a lot there, Tyson. There's a lot there.
It's very complex. It's not a
it is.
It's very complex.
It is. Well, I mean, that's why we're kind of in the midst. We can't do it sequentially, but we're in the midst of this sort of Pharma Series where I'm talking to people like yourself and trying to understand what the key issues are and how pharmacy, how do you get to that strategic place, right? And how do you get to that higher level of partnership with your suppliers? What are those things that are important? And I think you've addressed certainly a lot of those. Have you been working with other health systems and trying to lend your expertise? Share your expertise if people have been reaching out to you and said, wow, those numbers are phenomenal.
Yeah, so it's actually been pretty incredible. So MultiCare, we're part of the Vizian GPO. We do belong to a pharmacy aggregation group where there's multiple health systems that we leverage our spend together and look at opportunities. But based off of our success recently by decreasing inpatient spend by 24%, by having saved $7.5 million the last 2 years with our data analytics, some of the key strategic partnerships that we've created that have offered significant value and savings to the health systems. One piece being Mark Cuban's Cost Plus Drug, specifically in our retail space, and how that's been able to save $1.8 million over the course of a year for our retail pharmacies, as well as some of the other strategic partnerships such as Medigy, the online platform where wholesalers, where manufacturers are able to post excess inventories to liquidate. We've had a ton of health systems reaching out to us recently to see how do we replicate this. So MultiCare, we've been on a journey to becoming a world-class pharmacy enterprise. And if you were to try to define what that means, Tim Lynch, our chief administration officer, who used to be our chief pharmacy officer, but has recently been promoted, he would define that as we would want world-class health systems reaching out to us to ask, how do we recreate this? How do we
Sure.
this? How do we emulate this? And within the last year, we've had almost 28 different health systems reach out to MultiCare to ask specific questions. How have you been able to achieve this success? How have you been able to decrease inpatient spend by so much? Who are you partnering with for data analytics? Who is your automation company? What data analytics capabilities do they have? How are you forging these strategic partnerships with other entities that are outside your traditional GPO and wholesaler networks? And that's where we've been able to really shine and show, hey, pharmacy supply chain and MultiCare, we are a world-class enterprise, and we are looking to really change the way that pharmacy procurement is happening to really drive value, success, accessibility to those medications across our health system.
Is that a new service line, or is that a service line for MultiCare, or is it just?
We actually are standing up our own consulting service through MultiCare, specifically looking at targeting pharmacy supply chain, retail pharmacy, infusion, specialty pharmacy, and really helping other health systems create a playbook based off of the success that we have so that they can emulate and copy that success moving forward to achieve the same revenue, margin, and savings opportunities that we have.
Well, I promised folks listening that this was going to be a great one, and it was. Tyson, thank you so much. I appreciate your taking the time. If anybody needs to reach out to you, any preferred way through LinkedIn or email, or what's the best way that people can get a hold of you once they want to learn more about the secret sauce?
Ooh, and any way, and I'm happy to discuss this with anybody. Pharmacy is such a tight-knit community, and if I can share best practices with somebody else, there's obviously best practices that they have that they can share with MultiCare for us to continue on this journey that we're on to becoming a world-class pharmacy enterprise. So whether it be via email, whether it be via LinkedIn, whether it be any means of communication, please don't hesitate to reach out. I'm happy to discuss, and looking forward to any opportunities we have to network and collaborate together to be successful moving forward.
Great. Tyson, thanks again. Really appreciate it.
Thank you, John. Thanks for the time.
And that'll do it for another episode of Healthcare Rounds. Our guest today has been Tyson Frodin, AVP Pharmacy for MultiCare. And as always, I'm your host, John Marchica, CEO of Darwin Research Group. Please, if you like what you hear, subscribe, rate, review, wherever you listen to your podcast. See you next round.